Yeah, I'm happy to go first here.
Okay, hi everyone. This is Howard Mann speaking. Welcome to the STR webinar. I'm going to have Travis go first this week, so you should see his screen in a moment. Good.
All right, do you guys see my screen? So we don't have a lot of people on here this week. Brent, you and David have cases to show because I have 4 or 5. I can just show a few of them to start and then
I think
come back around.
show those. That'll be fine.
Okay.
Sure.
This is one I've got a mix of bread and butter stuff and some other curiosities. This is one that's more bread and butter, but I don't think we often see the evolution of a case like this. This is a lady who is in her 30s. She's a drug user, came in with fever. Actually had an abdomen and pelvis CT first because she had flank pain and ended up with what I think was a septic. Well, she had an infarct in her spleen, which you will see, shortly what that's from. But here you can see in her right lower lobe that she has a nice look of a peripheral infarct that's non-enhancing, and a couple of other little things too peripherally, and some little nodules. And on this study, so this was in earlier January, and you can see nice peripheral nodular foci of consolidation in the setting of bacteremia. Drug use certainly look like and behave like septic emboli. And I think that there was a nice observation made here, questioning whether or not there was some thickening of the tricuspid valve. And of course, there's a lot of motion here, but that case I showed last week with the mitral valve, in this context, unless you look for subtle findings, you might not see them, but she had an echo at this time already and had a tricuspid vegetation. So I think that's what that is. And she was bacteremic with methicillin-sensitive staph. But I think what really makes this case interesting is just the evolution of the findings that she has. So she was an inpatient this entire time. And as you can see, this is 7 days later. And now she has a large macroscopic emboli in both her right lower lobe and left lower lobe, with still evolving peripheral areas of infarction. And how much of this is superinfected, how much of it is bland hemorrhagic infarction, I'm not sure. I mean, clearly that looks like a septic embolus here too. And then these in the upper lobes, and again, a nice look of a peripheral infarct with that central ground glass absence, largely absence of air bronchograms, and then the peripheral higher attenuation. But what's really interesting is this study that she had yesterday. Let's see if we can get some long windows here. And you'll see that these macroscopic emboli here in her right and left lower lobe pulmonary arteries have evolved, and now she has this large mycotic aneurysm of both her left and her right lower lobe pulmonary arteries. So it's kind of interesting to have the time course and to see over a couple of weeks how these have dilated. And I'm presuming they're mycotic since she's been bacteremic and had, and I don't have any other explanation, because you certainly wouldn't expect an aneurysm formation from just bland emboli. So
Right.
I thought this is
very dramatic. Very dramatic. Wow.
Yeah. So she's scheduled to go to interventional today, and they were talking about coiling these. I'm not exactly. I don't know. I haven't been privy to that discussion. I just saw this in follow-up this morning. I'll let you know what happens with that. I don't know if that's, typically what you do or not. Certainly, I guess these could continue to enlarge and rupture, especially if they're true pseudoaneurysms and have lost integrity of the wall. So I don't know, but I just thought it was an interesting evolution of these septic emboli into these macroscopic pulmonary artery mycotic aneurysms.
It's interesting to answer the question, how much of the stuff in the pulmonary vessels on the previous was clot, infected clot, and even just inflammation. It's almost like they're surrounded by ground glass opacity in the lung even.
Yeah, right. Yeah, that's a good point, like in here.
Yeah, very dramatic.
Yeah. And she still had a little vegetation on her tricuspid valve too. I don't think she ever had like a huge vegetation that flicked off, but I don't know. It's kind of an interesting evolution.
Very, very dramatic.
All right, now this is a cool case. This is courtesy of my neuro colleagues yesterday, that showed me this and said, "What the heck do you think this is?" They had some ideas too. This is a lady who, I'm showing you a neck CT from 2005, and this is maybe the only interesting case of the thyroid gland I've ever seen, since us thoracic radiologists don't find the thyroid that interesting in most cases. But you can see in 2005, her thyroid is normal. And then check out what her thyroid gland looks like yesterday. And I'm curious if anybody, David, Howard, Brent, if you guys have ever seen this before. You can see there is uniform, marked, massive enlargement of the thyroid gland, and it's mostly fat, interspersed with some higher, presumably normal attenuation thyroid. And I had, I don't remember where I saw or heard of in the past the entity of thyroid lipomatosis. I didn't even remember the name, but I did a quick Google search. And I came across a couple of different papers. Let's see, do I have them both attached here? Yeah, I think this is one of them, right. So diffuse thyroid lipomatosis of the thyroid gland. This is one case report, and I'll show you the images first because it looks pretty darn similar. There's a little less parenchyma here, but they did a biopsy of this, and it was all mature fat and adipose tissue through here. And one of the things they talk about in here, I think they mentioned it in this paper, is that this may be idiopathic, but there's also entities where they describe amyloid deposition in the thyroid gland. I guess it was in a different paper that described that, but I found this other paper too. And what's really interesting is that, so lipomatosis in a 36-year-old with a kidney transplant, and I think I forgot to mention that between these two studies in 2010, she underwent a renal transplant. So that's the only thing that's changed. She did not have a history of thyroiditis, never had abnormal thyroid function tests. But it's really curious that this was another patient with a renal transplant who developed this. And when they biopsied this patient, that there was a lot of amyloid that was also deposited in the thyroid gland. And I'm trying to find, but it looks very similar as well. I mean, they could have cropped the image perhaps a little bit more. But I'm curious if you guys have seen this type of case before.
No, definitely not. I think I would have remembered that. That's pretty strange.
Yeah, no,
right. So there, and I'm trying to find the discussion in here. But there was so thyroid lipomatosis or diffuse lipomatous. I don't know if it's brown fat, if it's lipomatous hypertrophy. I mean, I don't know if they're going to do a biopsy in this case or not, but there was some discussion of amyloid. Yeah, here we go. Yeah. So one of the patients that they report here had amyloid deposits. So this patient had been on dialysis for a few years, has a renal transplant. So I don't know if there's going to be amyloid goiter with fat infiltration here, but I think it's mostly just fat, and who knows if there's amyloid in it as well. But yeah, so I'm calling this a case of thyroid lipomatosis, without anything, I don't have a better explanation for it, and it certainly doesn't look like a discrete tumor.
Very strange.
Yeah, and it's just interesting that we happen to have a neck CT showing a normal thyroid 10 years later, or 10 years earlier. So, David, any comment? I think he's on there. Oh, I texted a picture of it to Jeff because I knew he wasn't going to be on here today. I haven't heard back from him either. So,
can you hear me now?
Yeah, I can hear you now.
So, is she euthyroid or is she hypothyroid?
Euthyroid. So, in the prior patients that were biopsied, these were all normal thyroid, just interspersed with mature adipose cells. So I don't know. We'll see. And she had the neck mass, but I think my resident was saying that it was more she was coming in with venous congestion. And you can see this dilated right external jugular vein, and there's some narrowing of her internal jugular vein in this area. So
yeah, collaterals.
Yeah, but pretty interesting. All right, let me show another just bread and butter case. This guy came in on January 1st, 35, no sick contacts, no history. He traveled to Cape Cod over Thanksgiving and has been to France within the past year, but that's it. Came in with about a month of worsening weight loss, fever, chills, and cough. And of course, the resident that saw this says probably a pneumonia. There's nodular consolidation, and appropriately, raised the possibility of whether or not there were cavities and said, maybe this is TB. They were kind of suspecting that even though he didn't have risk factors, but I think it's just such an amazing case because it's one of the best CT, textbook CT cases of tuberculosis that I've seen with the big cavities. And some of these tree and bud nodules are so large. Like, I know, Howard, you always like to MIP these up, but these are so striking that you don't even have to MIP it to see how pretty the centrilobular nodules are. And it was just a really striking case. And this was confirmed as mycobacterium tuberculosis.
Yeah. Travel to South Africa, you said?
No, just to Cape Cod, not Cape Horn, or to anywhere else, and just in France. That's the only other place. So we're still not sure where his exposure was from.
South Africa would be the Cape of Good Hope.
Or Cape of Good Hope. Is Cape Horn, is that South America?
I think so. I forget.
Okay. Well, yeah, I'm going to trust your geography of South Africa for sure. So, but yeah, I just thought this was a really pretty textbook case.
Very, very.
Not requiring MIP. So,
all right. Any risk factors like incarceration or?
Yeah, no history of incarceration. He lives with a couple roommates, none of which are sick. Nothing else. So
HIV status.
His HIV is negative. Yeah, they've done a full workup. So, other than his travel, really nothing. So there's no good explanation at this point, other than he lives in a city. So,
hey, Travis, can I see the soft tissue windows to look at the? Is there any internal mammary lymph node enlargement here? I'm just curious.
And what makes you curious about that?
Well, just in, we're noticing more and more that there's, in many TB cases, there's internal mammary lymph node enlargement, and just many more than you could expect. And I don't see any here, but yeah, it's interesting.
Do they have pleural disease when you see that?
Some with, some without, so it's just something that kind of looking for recently. So
yeah, but no, I don't see any. But yeah, the take-home message here is don't forget about TB when this person comes into your emergency department. So, all right, Howard, I'll stop for there and let's swing back around if necessary.
All right. Brent, do you have some to show this week?
Oh, yes.
Good. All right, here you are.
Okay, let's see.
Good.
Okay, let me see. Can you see a radiograph here?
Good. Okay.
So this is a Grady patient in the 40s, I believe, who came in with this radiograph, and just looking at it quickly, you don't know, what's first thing that went through my mind, just briefly, for a split second, is is the patient's head in the way? What's going on here? Weird, folding of some tissue here, but just a very lobulated, large mass here sitting up here over the neck and upper chest, and you can tell it's not rising from the lung itself, and you can see nice vessels through, and the lung and mediastinal contours are not silhouetted here. So let me show you this. This is in keeping with Travis's case.
Brent, can we say that maybe there are small nodular or tubular opacities in the right lower lung at least?
Yes, exactly. Yes, there are a lot of nodules, a lot of nodular opacities here. And let me show you this is the neck CT, and you can see that there were, some nodules here. And let me show you you can already see there are a lot of dilated vessels, veins here in the anterior chest. Going up, you can see that large heterogeneously enhancing soft tissue masses that are actually rising from the thyroid, and actually metastatic from the thyroid. This was believe it or not, this was a papillary thyroid carcinoma that was, locally, aggressively spreading everywhere here within the neck, and you can see that the adjacent manubrium and upper sternum are involved here. It's narrowing vessels, which is why we saw the collaterals. You have multiple necrotic appearing lymph nodes here and soft tissue deposits. So this is just a really, you have an invasion into spinal canal. So this whole thing is related to papillary thyroid carcinoma, and not sure exactly how this, had not been. Apparently, this was went unnoticed for a while, and came to attention. So it is like, so many cases that we see, it's very advanced, much more than you would expect to be, this was responsible for that opacity on the chest radiograph. So I just thought it was the most dramatic case I've seen of that. But have you all seen a case that's dramatic?
I don't know.
Of that entity? So presumably, I believe that these nodules were, you can't, I don't have the full chest CT on anonymized here, but, presumably some metastatic nodules that we're seeing on the radiograph. So I just thought that was a nice accompaniment to Travis's case there.
We've never had this many interesting thyroid cases in one day.
I know. And here's another. This is a patient in his 50s, I believe, who has this appearance. And you might immediately jump to the looking at the trachea, the bronchi. There is tracheomegaly. There is enlargement of the main stem bronchi, and this corrugated appearance here, and you can see the central bronchiectasis, and it's getting to be a varicoid, it's both cylindrical and varicoid bronchiectasis. Coming down, you can see that there are multiple tree and bud nodules, and looks like a sort of a diffuse bronchiolitis pattern. But also you can see, as I'm scrolling through, I'll switch to the soft tissue windows here, that there is a mass in the mediastinum, an anterior mediastinal mass. So this patient had a history of recurrent infections, and the immunoglobulins were low. And I can't remember exactly what the immunoglobulin profile was in this patient, but this mass was resected, and of course this is a thymoma. So this was a case that we might have thought, well, could this be more near Kuhn even? But we would call this or I would call this a good syndrome, with chronic infections, presumably leading to a secondary bronchomegaly, and this bronchial distortion in the setting of ongoing infections due to the immunoglobulin deficiencies in the setting of a thymoma. So I just thought this was a nice, interesting case of good syndrome. I can't prove that there wasn't a coexisting primary tracheal and bronchial abnormality, but I presume that much of this is probably due to the recurrent infections in the setting of immunodeficiency that was chronic in the setting of a thymoma. So I just thought that was an interesting case of good syndrome, presumably.
That's a good case.
So
very strange.
It could be a collision case of, both a sort of more near Kuhn type syndrome plus good syndrome, but the patient was having recurrent infections and did have a thymoma, so I think I could probably justifiably call this good syndrome. Okay.
Wow.
And here's another case. I wish Jeff were on, because I think he would like this next case, but I think it's a good case of something. So here's a patient who is actually in the, I believe, 32-year-old patient. And this was read at an outside hospital as concerning for a central lung cancer, such as a small cell cancer and small cell carcinoma. But you can see coming down that there is a soft tissue mass in the right hilum that is infiltrative in appearance, and there are multiple areas of, there is certainly some contrast in a narrowed SVC, but there are some areas of calcified adenopathy here as well. And you can see, looking at the pulmonary veins, that the inferior pulmonary vein is completely gone. It's completely truncated by the soft tissue. The superior pulmonary vein is also very narrowed here. The pulmonary arteries are very narrowed here in the hilum. And just in looking for secondary signs of this entity, you can see that the right lung is small, as if this is a chronic process. You can also see nice hypertrophy of the extrapleural fat here. And you can even see some pleural calcification here and some pleural thickening. Let's look at the lung windows. We see, the typical appearance here of septal thickening throughout the lung, from pulmonary venous congestion and pulmonary venous occlusion. Let me show you so presumably, we're thinking this is a case of fibrosing hylitis mediastininus.
How about the spleen, Brent? Are there any calcifications in the spleen to go with histo?
Yes, there are multiple calcifications in the spleen to go along with histo. So presumably this is a fibrosing hylitis appearance, fibrosing mediastininus hylitis appearance that happened quite some time ago with the extrapleural fat hypertrophy and all the secondary signs here as well. The only questions I have are, first of all, do you agree? And second of all, let me show you the PET. So this PET was done, close to the same time. And my question is how, we do have some activity there. So how long should how long can a process like this be smoldering? Because I would presume that this happened some time ago. And we still have a lot of activity in the nodes. No history of sarcoid, in this case, or any history of diagnosed sarcoid yet. But how long could that smolder? Supposing this is a histo causing a fibrosing hylitis, would you expect that level of activity now?
I don't know.
Because I would have been happy just to call this, fibrosing hylitis, but there are some, there's some activity there, so that's convincing.
Yeah.
So when you tell me, guys, when you have lung edema and you get enlargement of mediastinal and hilar lymph nodes, just because they're busy passing a lot of fluid, are those nodes hot on PET? I mean, could this be a response to the fluid accumulating in that lung because of the obstruction of the veins and stuff?
Don't know.
I haven't really noticed that as a phenomenon yet. I mean, but not that hot.
And we didn't have bronchial obstruction here enough to cause any infection in the lung or something that might cause the nodes to be active.
I don't really see significant. There's a little bit of narrowing, but not obstruction.
Okay.
The pleural disease is interesting in and of itself. We've seen cases like this before, but clearly this person has calcified fibrothorax as well, which is interesting. Not that surprising, but one could easily ascribe that to the infection as well. It just produced a pleuritis as well.
And the whole lung is small, presumably because of that process. And so I would have thought chronic, this happened years ago.
Yep.
Right. Yeah, I don't know if a lot of the volume loss is due to a fibrothorax or if it's just from the chronic venous congestion, because sometimes you see that too. These fibrosing hylitis, mediastinitis lungs just scar down.
Yeah.
I guess as an ischemic response.
Combination of all those things, perhaps.
I mean, I think we're all agreed that this is a fibrosing hylitis, and I think you're probably allowed to have a little ongoing inflammation in those nodes. They didn't look that angry to me that I would invoke some separate process.
Why did they do the PET, Brent, just to confuse everybody?
It was called cancer outside. Okay. So on the outside it was called cancer.
And the non-attenuation corrected still show activity. It's not just calcification that's fooling us. I mean, I agree with David though. I think you're allowed to have some inflammation and ongoing metabolic activity.
Yeah, I mean, I would still say yes, that's due to this fibrosing hiatus. I just wondered if anyone else had noticed that before, because that's the only thing that kind of made me stop for a second. And but I think
I would just argue that there's ongoing inflammation, and they might want to consider some sort of therapy.
Yeah. So we'll see I'll see if I get follow up on this, but so, okay. And then I think I had another one, but all the cases came through here. So yeah, so I'll show that next time. So that's all I have.
All right, sure. David, do you have any perhaps?
I do. I've got a couple.
All right.
Hang on. Before you give me the screen here, Howard, let me make one little adjustment here.
All right.
Okay, ready to go?
Good.
So here's a roughly 40-year-old person, previously healthy, does have a little history of sinus disease, and had a lot of joint pain, a lot of arthralgias involving shoulders, bilateral shoulders and things like that, and then developed some hemoptysis. This is a chest radiograph around this time, and there's just this very subtle smudging here of vessels in the mid-right lung, and then once having seen that, you wonder, could there be a little bit on the other side as well? Did have a CT scan around this time, and he has quite a bit of ground glass abnormality, mostly central. He also had a peripheral eosinophilia that was pretty fierce, and eventually he had lavage, and he had a lot of eosinophils in his lavage fluid. So it was determined that he had some sort of eosinophilic process. Here are his sinuses, and you can see he's got quite a bit of sinus disease, more on the right than the left, and it's affecting the bone here immediately. So this is a chronic process. He's got a little bit of stuff on the other side, but it's mostly on the right. So he does have sinus disease, and he had more hemoptysis. He had blood on bronch as well. At this point, he also had a positive galactomannan. So this is the second CT scan, and he has a nodule now in the right lung base. So in the setting of the positive galactomannan, the concern was that this was aspergillus down here. But it turns out that this is the precise location where they did a transbronchial biopsy, where they found eosinophils and lymphocytes in tissue. And so this is actually a bronchbite down here that is probably filled with fluid, probably filled with blood from the biopsy. And it's a very discrete lesion. It's more discrete than you'd usually expect with aspergillus. And then there's some lore that's circulating around here, and I don't know whether you guys have heard this too, or whether it's substantiated or not, that hemorrhage, pulmonary hemorrhage, can cause a false positive galactomannan test. So it doesn't always indicate aspergillus. Have you guys heard that lore, or is that just local lore?
I don't know. I've not heard that.
Okay. So his unifying diagnosis is eosinophilia with and granulomatosis with polyangiitis. So EGPA, or Church-Strauss in the old days. This lesion is going to be left alone once it was recognized by our my alert colleague Greg Kitchka that this probably corresponded to the bronchoscopic biopsy, and we confirmed that with the location was confirmed. So this is a bronchbite, not aspergillus. This is pulmonary hemorrhage. Most of the ground glass stuff we're seeing. There was eosinophilia in the lavage and peripherally as well, and there were eosinophils in the tissue from the transbronchial biopsy. They did not identify vasculitis, but he's presumably going to get better on steroids, and they may transition to rituximab for him. So pulmonary hemorrhage in the setting of eosinophilia turns out to be EGPA, and almost got treated for aspergillus until it was recognized that this was a bronchbite down here. Okay, so
very good.
Yeah. Okay, so let me show you this person here who had metastatic cancer of the cervix that had metastasized to lymph nodes in the mediastinum and right hilum, and I think there was a lung nodule that was a little bit lateral to the right hilum at some point, and the person got radiation in 2008. So we don't have very many chest radiographs on this person, but this one does show that there is a hilar abnormality here, which is at different points in this person's history was probably initially tumor and then scar after radiation in 2008. So let me show you a CT scan from 2009. This is more than a year after radiation. And let me just show you what this right hilum looks like. It looks like mature radiation scarring here centrally. So not much to worry about there. But then let me show you what happened a few months later when the person's chemotherapy was changed. And we now went to, let's see, which is the more recent one now. This is our current one now. So we had a lot more consolidation around this right hilum at a point, this is about several weeks after chemotherapy was changed. At this point, there's also lung edema. The person was getting a lot of hydration, I think, and there's pleural effusion on both sides, right greater than left. So discounting the diffuse, mild, patchy lung stuff, the main abnormality here is this central consolidation, which corresponds to the radiation port. So this is a case of recall pneumonitis, which can be triggered by some chemotherapy agents that are considered to be radiomimetic. So somebody may have mature radiation fibrosis, you know, it's not very active on PET and so forth. You put this person on one of these agents that mimics radiation, and you can bring back the radiation pneumonitis that was there, might have been there earlier, but probably wasn't imaged because it was a typical finding after radiation. So this is recall pneumonitis in this person. It typically responds to steroids, and I think in her case it did well, but I don't follow up CTs past this. So recall pneumonitis, have you guys dealt with this before?
I don't think I've recognized an instance of it that I can recall, I don't think.
Travis, or you know, if it's not occurred at Emory, it doesn't really exist. So
I feel like we've seen ones that are potentiated by, you know, certain drugs, but I'm not really familiar with the term recall pneumonitis, but that's very cool. And
yeah, I like it. We have not used that term either.
okay.
Are there any drugs that are known to do that? Any, you know?
I think there are certain ones that are more likely to do it than others. I have a whole list of her chemo, and she got about 3 new agents at a few weeks before this occurred. So I'll try to include that information. There are certain ones that are classic for doing this, and I need to recall what those are.
Yeah, that's very interesting. My goodness.
Okay.
Yeah, let us know. I'm going to have to look that up in Google. I don't know anything about that.
Okay. So here's a woman who had lung transplant several years before, and I don't know how compliant she was with her drugs, but at this, in the last year or year and a half, she has become more short of breath, and she has mosaic attenuation here. You can see the sparsity of vessels in the bases and the darkness of the lung here. So we have this mosaic attenuation that, and we're probably getting some bronchial wall thickening here centrally. So this all fits very nicely with chronic rejection. Sorry, with chronic rejection. You know, I'm getting myself confused. I think this is a stem cell transplant. So I think this is graft versus host disease leading to obliterative bronchiolitis or constrictive bronchiolitis here, accompanying bronchiectasis. And the other thing here of interest is these apical lung lesions looking a little bit like the TB case that Travis showed a little bit earlier. So we have some lesions here that seem to be tracking airways. We have a later CT scan that shows now cavitation where we had that big nodule on the right. But if you look on the left now, we have some very nice tree and bud opacities over here. So this indeed is, as you probably are suspecting mycobacterial disease, this was an atypical mycobacterium, M. fortuitum. So we have mycobacterial infection in the setting of constrictive bronchiolitis. And I will, before I post this case, I'll get my history straight and find out whether this was a stem cell transplant or a lung transplant. I could look for sternotomy wires too, and that will give it away.
Yeah, the central airways look like
irregular.
Not.
Yeah. I think you're right. I think it was a lung transplant person. I think I saw some lower some sternotomy wires down there too.
When you go to the right upper lobe,
sorry, Howard.
Sorry, when you go to the right upper lobe, that cavity, can you connect it nicely with the bronchus? Was it a bronchus that was destroyed and became dilated? Or maybe it's hard to tell, of course. Doesn't really matter, but it's almost oval-shaped. Well, you can
I'm not quite sure.
We can certainly see a small bronchus leading right into it in its proximal medial portion. It doesn't matter.
So it could be a localized dilated bronchus, yeah.
Yeah, destruction of the wall and so on. But yeah, that's pretty dramatic. It occurred quite quickly, huh?
So lung, I'm pretty sure it's lung transplant, then constrictive bronchiolitis, and a opportunistic infection here. Okay, those are the three cases I wanted to show.
Thank you. All right, let me show you these. These are relatively mundane compared to what you've shown, but maybe I haven't noticed this before, but let me show you this case of very florid mitral annulus calcifications, an older person. Some calcifications, of course, within aortic valve leaflets. And then when I scrolled down, at some point I said, oh wait, there's more than just the annulus, because there's some that project right there as well. So let me show you that. And then we go a little bit further down and we see more of them. And sure enough, I read the ultrasound report, and they described calcifications in the ultrasound report described as quite large in the mitral valve leaflets themselves. So this is calcification in the leaflets. And then I got to thinking whether I maybe have seen this before, but it didn't register. So how often do you folks see or register calcifications, not just in the annulus, but even in the mitral valve in elderly people in the leaflet?
And I think some of it's extending into the chordae as well. And that may be what you're seeing, projecting more into the lumen. And I know it's come up on questions of foreign bodies. Like there was one case when I was at Grady that somebody thought that they had gotten shot in the heart because there was something in the LV, but it was just chordae calcification.
Okay. Yeah, they were described as calcifications in the leaflets as well, on the ultrasound, that is, report.
Yeah.
Well.
Yeah, and I think that some of that is too far from the valve plane to be just leaflet.
So maybe some.
Yeah, I think some of that may just be chordae as well. I don't.
Not that far.
Brent,
yeah.
Was Art behind you there too?
It also looks very elongated. It looks as if there's a string-like thing, and some of those. Back up a little bit.
Okay. This way, David.
Keep going. Keep going. Right there. So that one that just disappeared, it went by too fast. There. You see that string? Isn't that chordae shaped right there?
Yeah.
The little intermittent line.
Yeah. And so I think Howard, I think to answer your question, we do see this on occasion. I think it's just important not to mistake it for anything bad.
Yeah. Good. I'm sure that I've gone right by this and not reported it as an incidental finding when the exam's obtained for other reasons. All right, good. This one kind of goes into the theme of just have to think about alternative diagnoses. So the context here, and I'll show you some more information in a little while, is a patient with a history of malignancy and treated malignancy, has new opacity in the right lung. Not surprisingly, not too long afterwards, they did a CT. So let me get my dates right. So this is on the 12th, which is 2 days later. And this was ordered and done as a non-contrast CT. So we see a lot of abnormality in the right lower lobe corresponding to what we see on the chest radiograph. And yes, we do see this pattern of strange, or I just call it disordered aeration within that region. So there's consolidation, a very heterogeneous consolidation, and then seemingly here that disordered pattern of aeration that we, in a certain context, can associate with potentially infection, such as mucor mycosis, for example, in a patient that is an oncology patient. And that was just the assumption initially that this was an infection based on what you see so far. But I remember looking at that and looking at this pulmonary artery, and I got a bit lucky here and wondering, maybe it was triggered by the fact that her history and her presentation didn't seem that of someone that was infected that much. But that was the initial read. But as you might suspect, what I'm going to show you next is the CT that was done the next day. And I'll bring...
Before you go to that,
yep.
the right lower lobe pulmonary, can you go back to the right lower lobe pulmonary artery on the non-con?
Okay. Looking at the attenuation of it.
Sorry. Yeah, on soft tissue windows.
Is it a little bit...
Huh. It looks a little low, if anything. Maybe that's just...
I wondered, because I looked at that and I said, well, I wonder if that's a little bit dilated, and I wonder if there is something that's a little bit low there. So you're kind of warm, but as you'll see, it turns out that not all of this actually is what you now know is going to be there, which is embolus. So we'll go to that and scroll down here. So sure enough, you can see here that here is the clot here. So this is opacified up to that point. Then we have a big clot over here, distending that vessel, and a little bit going down this vessel. And certainly that's consistent with pulmonary hemorrhage infarction. So that's certainly an alternative diagnosis that one should always think of. Not everyone with this in the oncology ward has mucor or aspergillus or something bad, plain old pulmonary embolism. So, Travis, I think this is kind of in that area, and then the clot goes off right down there to that area.
Was the patient neutropenic? I missed your history.
Oh, let me get the history. Don't give mine myself. There's a history of previous pneumonia and pulmonary embolism. So the history goes back, as you can see, quite a few years. And she was back at the clinic. But a lot of her treatment was quite a long time ago, although she's got some skin and eyes GVHD, as you can see there. All right. This is the kind of case that we've shown before, but it's another example of it, so I thought worthwhile to show again. So the context here is an unfortunate patient with rather extensive metastatic disease from a colon cancer, extensive involvement of the liver, as you see there. And then let me bring up some thin cuts for you, which will be these. And then I'll do some MIPS. So in looking at this, there are some really subtle findings, but when I do the MIPS, you'll see that they do show up a little bit better. So for example, a place that I initially saw it was right here. So if you look at these peripheral vessels, they are just a little bit large and a little bit knobby. And then if you scroll around in a case like this, you can see, oh, maybe more of the same here. And then, of course, if you scroll around, you see more of the same. Right down here, I'll show you in a moment, are some little nodules and tree and bud-like lesions. And it's the kind of case where you then begin to scroll around and you begin to see the same kind of phenomenon in other places like that. So now let me make some MIPS, because these are very consistent with intravascular metastases. So here we have a MIPS around about 5 millimeter thick. And then I think when you look at those lesions like that, you can see that they are vascular tree in bud, and you can see them right there. And you can just imagine the tumor in the vessel, distending the vessel a little bit. And you can see that same thing right here. So I think a very nice case of intravascular metastases within small lobular arteries, arterioles. And we've seen this before. We usually see it in the cases of renal cell cancer, I think. But, look at that. But this is a patient with colon cancer. And I know David has shown some dramatic examples of that too. I think we all have.
So, I think there's a good chance that this metastasized from her liver, because hepatocellular carcinoma also likes to do this. These are tumors with easy access to veins. Like renal likes to go into renal veins, and hepatocellular can go into the hepatic veins and get back. And so can adrenal. I've seen adrenal cancers do this. So I think maybe the colon cancer got to the lungs via the liver.
Hmm.
Cool.
Yeah.
But, sometimes things are easier to recognize than describe. When I see this pattern, I think maybe knobby is a nice word to use for these vessels, right? They just have that.
Yeah.
If they're not frankly tree and bud type, they're kind of knobby vessels. They're just not smooth, and they're distended. But it's a fairly distinctive appearance in my experience. Not that we see that often, but I think when you see this, looking in this region, it's very distinctive, I think.
Let's call it Howard's knobs.
All right. All right, everyone. That's it for this week. Thanks for attending.
Thank you.
I'll see you same time next week.
Thanks, guys.
Thanks, everyone.
Thank you.
Bye.